Good afternoon and welcome to today's Payment Transformation webinar. I'm Paula Murray with HMSA's Provider Services Department. Now that we're well underway with our transition into payment transformation, based on feedback from all of our PCPs, we've implemented some changes to the Payment Transformation Program for 2018. Today, I'll be sharing with you changes that affect measures that have been carried over from pay for quality, and we'll also look at measures that are new for those who have been on pay for quality and are just transitioning into payment transformation this year. We'll briefly cover the engagement measures and the tools available to help you succeed in the payment transformation program. The second half of today's webinar, we will be taking a brief look at Choreo, and then we'll come back and look at our toolkit for payment transformation. Performance measures will be scored annually on an individual PCP basis by line of business. All participating PCPs are scored on all measures for which their member panels are eligible. The performance measures were selected for clinical importance and focus on meeting new goals for patient care, including prevention, well-being, access, patient-centeredness, and population health management. In the Payment Transformation Program, the performance measures are all scored on a calendar year basis, not on rolling quarters as they were in Pay for Quality. And this is really nice because if your patient comes in early in the year, you can see all of the care gaps that apply to them for the entire year. The majority of the Payment Transformation performance measures are measures you're very familiar with and have been carried over from our Pay for Quality program. We will continue with preventive cancer screenings for breast, cervical, and colorectal cancer. The 4 diabetes measures will also continue to be measured in payment transformation. These are diabetic eye exams, medical attention for nephropathy, HbA1c level at less than or equal to 9%, and blood pressure control at less than 140/90. Advanced care planning and BMI will also be carried over to the new performance measures. Well-child visits in the first 15 months of life and well-child visits in the 3rd, 4th, 5th, and 6th years of life will continue to be measured. Childhood and adolescent immunizations, as well as weight assessment and counseling for nutrition and physical activity for children and adolescents, are also being included in the payment transformation performance measures. If you've just moved from Pay for Quality to performance measures in 2018, you'll see there are only 6 measures that are new compared to what you're used to seeing in the Pay for Quality environment. And these here on your screen, these are the 6 new measures. The first one, tobacco screening and cessation counseling. This looks at the percentage of your attributed members who are 18 years of age and older who had an outpatient visit with an eligible PCP type during the measurement year. Be sure you have them screened for tobacco use and have tobacco cessation counseling if they screened positive. Screening for symptoms of clinical depression and anxiety looks at the percentage of attributed members aged 12 years and older who had an office visit with an eligible PCP type during the measurement year and who were screened for symptoms of depression using an approved screener. We will list acceptable screener tools, and that's in the 2018 guide, and you can find the guide available on HHIN. Claims reporting requirements are also located in the guide, so if you check for the code set for this measure, you can see all the codes you can use for numerator credit. And I believe that list is also available in the Provider Resource Center. I just want to point out, if you notice at the top right-hand corner of your screen, you see the CQM, and I've kind of coded the new measures so you know which lines of business each of these new performance measures apply to. So in this case, for anxiety and depression, this applies to both all 3, commercial, Quest, and Medicare lines of business. For adolescent well care, this is going to be looking at the percentage of attributed members aged 12 to 21 years who had at least one comprehensive well-care visit with a PCP or an OBGYN during the measurement year. The American Academy of Pediatrics and Bright Futures recommends well-care visits for patients age 11 to 21. Such visits should include a history, height and weight, body mass index, blood pressure, vision and hearing screening, developmental behavioral assessment, including the depression screening, physical examinations, immunizations, and anticipatory guidance. Another new measure is the developmental screening in the first 3 years of life, and this is for your percentage of attributed member children screened for the risk of developmental, behavioral, and social delays using a standardized screening tool in the 12 months preceding their first, second, and third birthdays. American Academy of Pediatrics and Bright Futures recommends developmental screening at 9 months, 18 months, and 30 months for early identification of developmental disorders. And a complete list of acceptable screeners is available on page 59 of the Payment Transformation Guide. Okay, moving on to some updates to existing measures. I wanted to share some updates to the breast cancer screening measure. We have added 3 new service codes for numerator credit in this measure, and the 3 new codes apply to patients who elect to receive digital breast tomosynthesis in place of traditional mammograms. While we are accepting these new codes for numerator credit, if the patient elects to use the digital breast tomosynthesis, this is still subject to their plan benefit limits. So if it's not one of their plan benefit limits, it may result in an out-of-pocket cost for the member. Effective January 1st, CMS is no longer accepting these 3 codes for breast cancer screening, the G0202, G0204, and G00206. And those were replaced by 3 new codes, the 77067, 66, and 65. And we presented this at our last payment transformation webinar, and I think it was a little bit confusing. So I just want to clarify. Looking at the previous screen, if you're reporting a HCPCS code G0279, I have here to list it separately in addition to the G0204 or 0206. And this is just for numerator credit. So while CMS is no longer accepting these G codes, if you've already sent in your claim with the codes, you will still be receiving numerator credit. Just as a matter of if you're sending your claim to CMS for payment, they won't pay based on these G codes. Okay, moving on to diabetes eye care exam. So this is for your percentage of attributed members with diabetes aged 18 to 75 who received a retinal or dilated eye exam by an eye care professional in the current measurement year or a negative retinal exam in the prior measurement year. And you can also receive numerator credit for patients who have had eye enucleations performed anytime during their history. For diabetes medical attention for nephropathy, this is for your diabetic members aged 18 to 75 who had at least one test for microalbumin during the current measurement year, or who had evidence of medical attention for existing nephropathy, with a diagnosis of nephropathy or documentation of microalbuminuria or albuminuria. ACE and ARB therapy during measurement year is also acceptable evidence. And we're also allowing numerator credit to include prescriptions for sacubitril valsartan as an allowable hypertensive combination. So denominator criteria has been modified to include only outpatient encounters with a diagnosis of diabetes with the following provider types you see on your screen. This applies to all 4 measures. So members aged 18 to 75 who at the end of the measurement year had a diagnosis of diabetes, either type 1 or type 2, by a provider qualified to make the diagnosis of diabetes for this measure. Patients with diabetes can be identified during the measurement year or the prior measurement year through pharmacy data, and that would look at patients who were prescribed insulin or oral hypoglycemics or anti-hyperglycemics on an ambulatory basis. The prescriptions to identify patients with the diabetes include insulin prescriptions and oral hypoglycemics, anti-hyperglycemics prescriptions. At least 2 visits with an eligible provider type where diabetes is listed as a diagnosis will count, and those eligible provider types, again, are on your screen. And just a note, telehealth visits billed with a place of service O2 will not qualify as outpatient visits. For body mass index, this isn't a new measure, but what has changed is the denominator criteria to include only outpatient encounters with an eligible PCP type that's listed here on your screen. Okay, the next change is immunizations for adolescents. So, 1 meningococcal conjugate vaccine on or between their 7th and 13th birthdays, and 1 Tdap on or between their 7th and 13th birthdays. So, the first and second doses must be administered at least 146 days apart, or at least 3 HPV vaccines with different dates of service on or between the 7th and 13th birthdays. And we'll specify the acceptable vaccines in the guide for this code set. And I believe that's also available in the Provider Resource Center. Influenza vaccine is a new measure to payment transformation as opposed to pay for quality, and this will look at your attributed members age 18 and older who receive a flu vaccine during the measurement year. And the last new measurement, if you're new to payment transformation, is the Sharecare Real Age. So Sharecare Real Age is applied to members age 18 and older who complete the Sharecare Real Age assessment at least once during the measurement period. So we didn't count this last year due to some technical difficulties in transferring data, but we have reinstated it for 2018. But as you can see, the minimum threshold is really low. It's only 5%, and target is at 10%. And just wanted to point out that this only applies to commercial members, not to your Quest or Akamai. So what we found in the past is some of our PCPs with the highest percentage scores on this measure have actually used some of the tools available to them from our toolkit. We have promotional posters, table tents, and rack cards for your waiting room. We also have a prescription pad where you can write your patient's health metrics for the real age test, such as their height, weight. If you have a tape measure, you could give them waist size, blood pressure values, and some of their lab results. While it's not necessary for them to have this to do the real age assessment, it does help them get a more accurate picture. So if you're interested in any of these materials, simply email us at psinquiries@hmsa.com and we can get a supply over to you. We also have an order form available in the Provider Resource Center that you can fax to us. Okay, weight assessment and counseling for nutrition and physical activity. We now have a new ICD-10 code that you can use for numerator credit, and that is the Z71.82 for physical activity or exercise counseling. You can still use the Z71.89 code and receive numerator credit. For our Akamai line of business, review of chronic conditions, this year's measurement period will be January 1st through September 30th, with supplemental data being accepted for 1 month after through October 31st. Also new this year in payment transformation is patient exclusions for members who are living in a long-term care facility and have been institutionalized at least 6 months during the measurement year with supporting documentation. So for those patients, you will need to submit a request for reconsideration each year. And this year, we will begin accepting those R4Rs on July 1st. So once the patient's been in 6 months, then July 1st, you can start requesting the exclusion. Okay, we covered all of the measures that fall under the PCP performance, but I wanted to take a quick look at the physician organization performance measures. While some of them are PO measures, the PO as a group will be relying on the individual PCPs to complete some of these measures. For your attributed members age 65 and older, the rate of discharges for chronic ambulatory care sensitive conditions, or ACSC, per 1,000 members. An ACSC is a chronic health condition and it can be managed or treated in an outpatient setting. Attributed members age 65 and older as of December 31st of the measurement year who were discharged from an inpatient facility with a primary diagnosis or procedure code identifying chronic ACSC will be counted, and members attributed to the same PCP during the month of January and December will be counted. You can see page 72 of the Payment Transformation Guide for a list of all of the conditions. For emergency department visits, in the denominator, the count of avoidable ED visits as identified by the primary diagnosis code. The ED visits that result in an inpatient admission are considered unavoidable. In 2018, compliance for this measure is based on timely submission of a Plan Due Study Act or PDSA type report by the physician organization, and details for that are on page 73 of your guide. And the next one is the percentage of members 18 and older who had a diagnosis of hypertension and whose blood pressure was adequately controlled during the measurement year, based on if they're 18 to 59, if their blood pressure was less than 140/90, or age 60 to 85 with a diagnosis of diabetes, whose blood pressure was less than 140/90, or patients 60 to 85 years of age without a diagnosis of diabetes, whose blood pressure was less than 150/90. If there are multiple blood pressures on the same date of service, you can take the lowest systolic and lowest diastolic blood pressure readings on that date as a representative blood pressure. The PO will be accountable for sharing and discussing information with their PCPs, and this will be measured using an annual survey questionnaire sent out to the PCP. So that'll let us know how well your PO is communicating with the PCP members. And for the last one, the Children with Special Health Care Needs Screener. This applies to members age 3 to 18 years of age who are screened for special health care needs every 3 years. The CSHCN Screener is a tool developed by the Child and Adolescent Health Measurement Initiative to identify children with special health care needs for quality assessment and population-based health applications. So we'll be looking at your attributed members age 3 to 17 as of December 31st of the measurement year who were screened for special health care needs using the CSHCN screener during the measurement year or 2 years prior. So each year, 20% of a PCP's base PMPM band rate for each line of business will be at risk based on the PCP's performance on a limited set of foundational engagement measures. The engagement measures are intended to outline key behaviors or activities that will help PCPs succeed in the payment transformation model. The engagement measures will be scored annually, and that will determine the portion of the following year's base PMPM band, which would be at risk, that the PCP will earn for each line of business. So So this can be found on page 11 and 12 of your payment transformation guide. For each engagement measure, PCPs will either earn all or none of the credit across all 3 lines of business. The weight of the PCP engagement measures have slightly changed from last year, and this is due to the removal of the Share Care engagement measure. So once you've completed your Share Care engagement measure in 2017, we took that measure out, and now we've increased the percentage across the remaining 4 engagement measures. The physician organization will be evaluated on the engagement measures on a quarterly basis, and measure requirements and thresholds can be found in Appendix E of the PT program guide. Each quarter, HMSA will determine whether the PO meets or doesn't meet the requirements for the engagement measures. No partial credit will be awarded, and credit for the measure will be applied to all lines of business. The weighting of these measures has not changed for 2018. It's the same as it was in 2017. And the measures will be equally weighted within each line of business as indicated in your table here, so 20% for each measure across each line of business. Social determinants of health data collection will continue to be unscored this year. Your PO must have an aggregate performance quality score across all lines of business and all member PCPs in the PO with an equivalent to earning at least 50% of the total maximum potential performance payment for the PCP performance measures during the measurement year. The total cost of care calculations will not include drug costs associated with drug plan riders and behavioral health services. So those 2 are excluded from the calculation. And the total cost of care performance will only be calculated on a PCP's medical spending trend for HMSA commercial plan members. So we will not be looking at your Quest and Akamai members for total cost of care. And there will be no outlier exclusions applied to the calculation. So if you've had that one rather expensive, maybe cancer patient or a patient hospitalized for a long time, those costs will all be calculated in. Another feature in Cozeva allows you to examine your total cost of care. The total cost of care dashboard provides details on the cost of each PCP's panel. The data only includes commercial members and doesn't include any drug or behavioral health costs. So you're able to see your top 10 patients with the highest cost and how those costs are distributed, as well as how your total cost of care compares against your PO and how it compares against the entire HMSA network. There are multiple tabs on this screen, and I kind of pointed those out by using the red arrows that you see. So you're not going to see those red arrows when you're logging into Cozeva. You can see not only your top 10 patients by cost, but other tabs will show you your top 10 patients for hospital utilization, your most frequent emergency department utilizers, those with the most office visits, and the most imaging claims. There's also a lot of other information that you can find in your total cost of care dashboard, such as your social comparison graph, clinical panel risk score, social comparison graph, your top 10 charts, cost utilization, hospitalization, emergency department, office and imaging, the ones I just covered, your total cost of care breakdown bar, your total cost of care PMPM or per member per month, your PO's medium total cost of care PMPM, and there's some other things pertaining to risk score that you can drill down to in the total cost of care. The goal in the attribution process is to reflect members' preference for a provider as their PCP, either by member selection or based on their office visit patterns. The PCP's panel is based on HMSA's attribution methodology, which consists of member selection at this time. We're no longer using claims history as a way of identifying a patient's PCP. Patient attribution has been a really big part of our pay for quality and PCMH programs from the time we started. But under payment transformation, providers are paying greater attention to the number of patients on their panel because it's a key factor in their monthly payment. Your monthly PMPM global payments are based on the previous month's patient attribution. So your global payment for August was based on your member attribution from July. This becomes especially important when a patient has an HMO, Quest, or Medicare Advantage plan. In those cases, your attribution aligns with PCP information in HMSA's membership database, and that information is also displayed on HHIN. So this outline you see here kind of shows you the workflow of adding a member to your panel in Cozeva for HMO, Quest, and Akamai Advantage members. So first you're going to verify the PCP information on HHIN, and it's important to verify your PCP information on HIN because our attribution is based on this information. And we'll talk a little bit more about HIN coming up. Then you'll have your member sign the patient attestation form. Go ahead and add the member to your panel in Cozeva, and then you're going to fax that form to HMSA if they are HMO, Quest, or Medicare Advantage. For our commercial members, you will not be sending that form to HMSA. So it takes about 10 business days for us to process your request, and then at that time, you'll file the attestation form in your member's medical record, and the member will then be attributed to HMSA's enrollment database at the end of the month, and they will receive a new membership card indicating who their PCP is that they've just selected. So to verify the PCP information on HIN, and again, this applies just to HMO, Quest, and Akamai Advantage, the steps you see are extremely important to ensure attribution to the PCP and timely monthly PMPM payments to the provider. So first you'll need to log into HHIN, click on the eligibility for the type of plan the member has, whether that's HMO, Quest, or Medicare Advantage. Then you'll enter the patient's information, so their name and their date of birth, or their ID number, their HMSA member ID, and their date of birth. Then you're going to click on the member's name, that's underlined, and this brings you to the eligibility screen. You're going to scroll down to the bottom of the page under Primary Care Provider. You're going to click the little plus symbol that's next to the primary care provider, and that'll expand the information listed. You'll verify the name displayed under Primary Care Provider name, and if your name or your provider's name is not displayed on HIN, you want to ensure the patient is informed and agree that they want you as their PCP. Explain your role as their PCP and the significance of them signing the PCP selection form. Then if the patient agrees, you'll go ahead and have them sign the form and fax that form back to HMSA. If you or your office do not have access to HIN, you can contact HMSA's HHIN help desk at 808-948-6446 on Oahu, or toll-free at the number you see at the bottom of your screen. We have our patient attestation form available online in the Provider Resource Center, and you can use the URL you see here on your screen to retrieve it. And this form is available in several different languages: English, Chinese, Japanese, Korean, Ilocano, and Vietnamese. And we also have a form for our pediatricians where they can list multiple children on one form with one PCP's name. So once you've had your patient go ahead and sign the form, and you've explained your role as well as your expectation of the patient, go ahead and add the patient in Cozeva. So you're going to need to complete the necessary information shown here by the green arrows, and that will add the patient to your panel in Cozeva. If you're covering for another physician, you're only going to select the first option, and this allows you to view the patient's medical record. If this is a new patient for you or an existing patient who's not currently attributed to your panel, then you're going to check both boxes. This allows you to both view the medical record and add the patient to your panel in Cozeva. When you're in Cozeva, you can easily identify members who have dual coverage. The member coverage IDs are underlined as you see here in this slide. So this example, the patient has an HMSA federal plan as well as, it looks like an HMSA Quest plan. So because both of these are underlined, you can tell that they're both active plans. Since members with more than one HMSA plan may only be attributed to one provider, the attributed provider is aligned with the PCP assignments in HMSA's enrollment databases, which are also displayed on HIN. Anytime a member has dual membership with an HMO, Quest, or Medicare Advantage plan, it's important to verify that the provider's name is displayed on the HHIN network. This is done to ensure the patient is attributed appropriately and the provider is paid their monthly PMPM. So for example, the PCP information is updated to reflect the provider's name. For the PPO and HMO plans, attribution is based upon the PCP displayed on HIN for the HMO plan. The PCP names displayed on HIN match if the patient has HMO and Quest. Attribution is based upon the PCP displayed on HIN for the HMO plan. Okay, at this time, I'd like to introduce you to Alyssa Castillo. She's going to be showing you some of the features on Choreo, and Choreo is scheduled to be launched on May 1st, 2018.
Thanks, Paula. So we're going to talk a little bit about how some of these different processes that you're currently doing in Cozeva will transition once we go live on Choreo on May 1st. So I'm going to be signing in today as a provider on Choreo so that we can see what the view is going to look like. Most of you should have already received some training on Choreo from the different PCP trainings that we've done or any of the webinars that we've been holding. So we're going to talk about a couple things. First, we're going to go over panel management, how we can see the patients in our registry, and what the new process is going to be for adding and removing patients. And then we're going to talk a little bit about supplemental data and requests for reconsideration. Here we can see that I'm logged in as a provider, Dr. Diamond Zaragamba, and this is the provider that we're going to use for today. The environment that I'm using within Choreo has all fake patient information, and as we can see here in this All Patients Registry, we're looking at all of the patients that are currently attributed to Dr. Zaragamba. We can see some information about the patients on this list here. This All Patients Registry is going to show all of the active or current patients on her panel. So we can see things like the patient's name, date of birth, and gender. The member ID is going to show the member ID for the contract that's shown in the column next to it. If we hover over the member ID by putting our mouse directly over that number, we can see any other IDs that Choreo has. So for example, if the patient has dual HMSA insurance, we'd be able to see the member ID for that other HMSA insurance. Similarly, for the contract, if we hover over that contract, we'll be able to see any other contracts for dual HMSA members. We can also see things like the number of open care gaps that the patient has, and if I put my mouse over that number, I can see exactly what those gaps are. And then we have some different information regarding risk, the current attribution status, as well as the provider that that patient is attributed to. We can search for patients within this list using this search box here. So we can search by patient's name, date of birth, or member ID. And then we can also add and remove patients using these two buttons here on the corner. To see details about an individual patient, we can simply click on the patient's name, and that's going to pull up the patient detail screen for this patient. This is where we can see information coming from all of the different sources of data that Choreo is currently receiving, which include claims data from HMSA, lab data from both clinical and diagnostic labs, hospitalization, admit, discharge, transfer data, as well as clinical data coming from the EHR. We can see all of that information by going into the clinical tab here. And there's two ways that we can look at this information. First, we can look at it from a timeline perspective, so looking at all of the information sorted by date. And the second way that we can look at it is by category. Significant events is going to show us any hospitalization activity that the patient has had, and then I can use this drop-down menu here to look at information in any of these other categories. For example, if I look at diagnoses, I can see all of the diagnosis codes, description of that diagnosis, the dates that it was diagnosed, and then I can also see things like the rendering provider as well as the source, so whether the information came from claims data or from the EHR. We can also see things like the number of open care gaps and details on what those care gaps are for a patient. If I click on this care gaps tab here I see all of those open care gaps listed for the patient, and I have this actions column here that allows me to take action on the measure directly from the screen. So from here, I can add a note specific to the measure, add or view an attachment, enter supplemental data, or submit a request for reconsideration. And we'll go through those things in just a couple of minutes. Now going back to adding and removing patients from the panel. To add a patient to the panel, as Paula was saying, this is always going to start with a discussion between somebody in the practice and the patient to ensure that the patient is aware of what the relationship means if they're choosing a new provider, and that you have their consent to add them to the panel. Once somebody in the practice has had that conversation, you can click this green plus sign in the All Patients registry to add that patient to the panel. If we're adding a patient to our panel that is attributed to another provider within our practice, we can simply search for the patient by their name, and we'll be able to pull them up because we will all have practice level access. More times than not, we're adding a patient that is attributed to a provider outside of the practice, and in order to do this, we need to click this checkbox here for Break the Glass. Break the Glass just means we're searching for a patient outside of the practice that we don't currently have access to. In order to search for a patient outside of the practice, we can see here that we need to know the patient's name, date of birth, member ID, and gender. The member ID is going to be the member ID that's on their insurance card. So here for PPO, HMO, and Akamai, it's going to be the R with all of the digits that follow. And then for Quest, it's going to be all of the numeric characters, including all of the leading zeros. So here we'll need to enter the patient's last name, first name, date of birth, their member ID, and the gender. Once we enter all that information, we'll click this search box here, and that will search for the patient. And here we can see that this patient is currently attributed to another provider, Dr. Prima Gardner. I can select that patient, and then click this Add button here to add that patient to my panel. That's going to pull up the second part of this Add Patient form, which will populate some information about the patient at the top, and then we have this Terms and Conditions box here towards the bottom. The Terms and Conditions is asking the practice to attest that somebody within the practice has had a conversation with the patient to designate the new PCP for that patient, and that you have the patient's consent and their knowledge that you're adding them to your panel. This Terms and Conditions is going to replace the need for the signed attribution form. So once we go live on Choreo, rather than having to have that patient sign the attribution form and fax it over to HMSA, now all we're going to do is read through the Terms and Conditions here and click this checkbox that says, I agree to the Terms and Conditions. Once we do that, we'll hit this Print and Submit button, and it will show this one page that we'll need to print out and hand to the patients. This one page here tells the patient that they've just selected a new PCP. It gives them information such as HMSA member services contact information, tells them that they may be receiving a new insurance card with their new provider's name on it, and is really just meant to give to the patient for their records. The patient doesn't have to sign this form or give it back to you. They can just take it home with them after their visit. This is going to be the process for all lines of business. And to remove a patient, we'll just select the patient that we want to remove from our panel, and we'll use the red minus sign instead. That will pull up this window here that asks us to select the reason that we're removing the patient from the panel. So either the member is deceased, they've moved outside the service area, we're transferring care to another provider. In this case, you would specify that new provider's name, or we're discharging the member from practice. Once you select the reason, you'll hit the Submit button, and that will submit the request to remove the patient. Throughout the month, these add and remove requests happen within Choreo for all lines of business. Every day, Choreo sends HMSA a feed of all of the requests that were made throughout that day, and then HMSA membership will process all of those requests. At the beginning of the next month, a new attribution file will be sent to Choreo where all of those changes will be reflected. The transfer registry and the attribution activity log were meant to give providers and practices more visibility into how patients are moving on and off the panel. This transfer registry is going to show any patients that you as the provider have transferred to another practice or that another provider has transferred over to you. This pending add to panel is going to show any patients that another provider has transferred over to you. So here we'll see the patient's name and some information about them, the date that the request was made. The from is going to show the original provider, and your name would be in the to provider. And then in this actions column here on the far right, we'll be able to accept or decline adding this patient to the panel. So anytime another provider requests to add a patient from their panel onto your panel, you will have the ability to accept or decline that patient. The pending removal from panel is going to show any patients that you as the provider have requested to transfer to another provider. So here we can see that this patient is transferring from our panel, Dr. Zaragamba, to another panel, Dr. Prima Gardner. You will have within the entire month to accept or decline patients that are in this pending status. And once that action has been taken, the patient will move out of this pending status down here into the completed transfer. And under the status column here, you'll be able to see whether that patient was accepted or declined from the panel. If no action is taken to accept or decline a patient throughout the month, when the new attribution file is sent over to Choreo from HMSA, that pending status will get canceled and that patient will stay on the original provider's panel. The attribution activity log is where we can see a historical list of all of the adds and removes that happen from patients within our panel. So here we can see some information about those patients. The status will show whether they were added or removed, the date that that happened. The from is going to show the original provider, and the to will show the new provider. And then in this requested by column, you'll be able to see who initiated that request. This is going to get updated as soon as those activities to add and remove patients are done within Choreo. If that happens for any of your patients, you will see it reflected here. Next, we're going to talk about entering supplemental data and submitting a request for reconsideration. And for this, I'm going to go into this tasking module. You may remember that there are a couple of different ways that we can submit supplemental data or a request for reconsideration within the Choreo platform. So I'm going to show you here a couple of different ways. Within the tasking module, we can see any patients that are on our panel that still have open care gaps, and there's a couple things that we can do within this module. Here we can see the list of all of those patients at the top here. We can also filter this list, so if I wanted to look at patients just within a certain line of business, I can select it from here. And I can also drill down to see patients that have a specific measure still open. So for example, if I wanted to look at just my payment transformation measures and look at all of the patients who still have a breast cancer screening measure still open, I can filter the list by selecting the breast cancer screening measure here. I can also search for a patient using the search box, and then this list here is going to display all of the patients based on any of the specifications that I chose above. Whichever patient is selected here in this top list, that is the information that we're going to see on this bottom list. So here I can see details for this patient, Amanda Baggins. I can see all of the open care gaps that she has, and then I see that same actions column that allows me to take action on the measure. This third icon here that looks like a clipboard is my supplemental data icon. To submit supplemental data, I can click on that icon and it'll open up the supplemental data form for that measure. I will enter the necessary information, so the procedure date, choose the appropriate procedure code, and I can enter any other information that I have. I can also use this attach record to upload any documentation. Under payment transformation, you are not required to upload documentation with your supplemental data. However, all supplemental data is subject to audit. So once I enter all of the information here, I can just click this submit button and that will submit that supplemental data for that patient. I can also submit a request for reconsideration if there is a reason why the patient should not be included in that particular measure. So for example, if the patient had a hysterectomy but they're still on my cervical cancer screening measure, I can use this fourth icon here that looks like a person with a minus sign to enter that request for reconsideration. When I hit that button, it's going to pull up the request for reconsideration form where I will enter the reason that I am requesting denominator exclusion for that patient. Here I can use the attach record and upload any documentation. For the request for reconsideration, you are required to have sufficient documentation to support that denominator exclusion. And then once I'm finished entering all the information, I will click the submit button here. This process is going to be a little bit different than what it currently is today. You'll no longer need to fax over the PDF form to HMSA and then wait for the mailed letter on whether or not your request was accepted or declined. Here you'll enter the form within Choreo, and all of the requests that you have submitted will live here in this R for R queue. You'll see a list of all of those requests that you've submitted, and then in this R for R status, you'll be able to see where that request currently is in the process. The reviewing committee can communicate back and forth with you directly within Choreo, and then once the decision has been made to accept or decline the patient or the request for that patient, you will see that status reflected here. Okay, now I'm going to pass it back to Paula to talk a little bit about the toolkit.
Okay, so just want to kind of point out that while we have been introducing Choreo, we do want you to continue using Cozeva on a daily basis until that time where we do transition on May 1st. But in the meantime, I do want to give you the access to our tools and resources that are available in Payment Transformation. The toolkit's available in the Provider Resource Center, and it doesn't require a username or password. It is a public website. You just need the URL, which you see here at the bottom of your screen. In the toolkit, we have lots of information. We have an overview of the Payment Transformation Program. You have links to the PCP selection forms in the different languages. You can look at sample payment reports. We also have guides to how to code your claim to receive numerator credit in the performance measures. Lots of other great tools to help you, as you see on your screen here. You can also access the toolkit from the hmsa.com website. Just scroll down till you see the link for providers. You click on the link for providers, and that takes you here to this screen where you can find a link to payment transformation under programs. We also have our training page listed here where you can access videos of previous webinars, and those are various topics, not just payment transformation. And we also have available PS inquiries at hmsa.com. If you have any questions, you can email us or call us at the numbers you see on your screen. But of course, keep in mind your physician organization is your transformation leader, and try to use them as your first stop. If perhaps they can't answer the questions for you, then go ahead and contact Cozeva if you have Cozeva-specific questions or need a little bit of training on Cozeva, or go ahead and call HMSA and we can have your provider engagement lead or one of our other employees reach out to you. And if you need any training or support for your office or your PO, our training team can come out and do some training for you. And I just wanted to point out, we've been working really hard over the past few months to get payment transformation payment summary reports online, and these are posted to HIN. So right now we only have reports loaded from April 2016 through February 2017, and we're hoping to get the rest of the 2017 reports loaded. I'm not quite sure if they've been posted just yet. So if you're going into HIN, it's located on your RTP page. You'll enter the search date range and select a payee ID from the drop-down box. The search result will pull up both payment transformation and report to provider documents if you have any that meets the search criteria, and that would be displayed for you in a grid like you see here on your screen. And last but not least, I want to remind you that we have our Payment Transformation User Guide available in HHIN. The guide provides details on the program, describes the roles and relationships between the PCP, the physician organization, and HMSA. And the guide is only accessible by logging into HIN. And it's a secure website that requires a username and password. If you don't already have access to HIN, or if you have new staff who need access, please contact the phone number you see here on your screen so we can get everyone their own unique login. Okay, that brings us to the end of today's webinar, and at this time we will go over the questions and provide you with some answers.
So the first question is, can we see the total cost of care for same specialties in Cozeva as well as Choreo?
So right now you cannot see total cost of care for other providers of your same specialty in Cozeva.
And the total cost of care modules within Choreo will be released a little bit later, but you will be able to see the cost of care information on Choreo as well.
Will it be across specialties? So if I were a pediatrician, would I be able to see other specialties, other people in my specialty,
Regardless of PO?
Or just my information?
I believe the total cost of care information will be specific just to your patients within, your panel, and not across specialties.
The next question is in regards to the completing the R4R in Cozeva. The PT guide does indicate that it's 4/1 that you can start because we had originally anticipated the launch for Choreo and 4/1. Do they need to wait till May 1st to submit the RFRs?
Yes, you will need to wait till May 1st to submit your request for reconsideration. So once Choreo is launched, then you can go ahead and submit the R4R.
The next question is in regards to checking on HIN as well as Cozeva. HMSA is recommending that the PCP should check both Cozeva and HIN to verify attribution for Quest, Akamai Advantage, or Medicare Advantage type members, as well as HMO. Is that correct?
Yes, you will. If you're looking in Choreo, and you may see the PCP as your name listed, but sometimes you might check HIN and it shows a different PCP, and that's because someone may have made a change in Cozeva, but we didn't receive a patient attribution form, so we didn't change our membership file. So what's in HHIN is really what you should be relying on, because that's where we're going to pull our payments from for your patient attribution. So if you see a different PCP's name in HIN, you want to do a little bit of research. Has the patient maybe changed PCPs via going to another doctor, or do they maybe call HMSA to make a change? But if you see a discrepancy where there's a mismatch, we're going to be looking at what's in HIN as the source of truth of your payment.
Okay, and the next one is in regards to when is the best time of the month to add patients in time to get the patients paid, or get paid the following month?
So you want to try your best to add patients as soon as possible, but of course, the first half of the month is the better time to add them, because that gives us some time to do the work we need to do on our side to make sure that they're properly attributed to your panel for the payment of the first of the following next month. So we understand patients are going to come to your office anytime throughout the month, but just keep in mind that we need about 10 working days to be sure to get them attributed to your panel. So if they come in the second half, they may not make it by the first of the next month, but they will be attributed the following month.
So this next question is actually for Choreo, for Alyssa. Is the logic entering supplemental data in Choreo the same as it is in Cozeva?
It is, yes.
So all the drop-down boxes with information pertaining to the CPT codes and everything is the same, am I correct?
Yes, so entering supplemental data in Choreo will be very similar to Cozeva. One thing that I will note here is that with the EHR integration, it is going to allow us to get clinical data directly from the EHR to automatically close care gaps and reduce the amount of supplemental data that you'll have to enter. So as we continue to integrate with the different EHR systems, we will be reaching out to each of the practices individually, but it's definitely something to consider because it will help to alleviate the amount of administrative burden that you're having to do in regards to supplemental data entry.
The other question is in regards to the meningococcal vaccination. Right now, new guidelines do say 2 separate meningococcal vaccinations. However, it does appear in our guide that we're looking for just one for right now. If you do a second one, it's even better, but right now we're just looking for one between the ages of their 7th birthday and 13th birthday. In regards to the flu vaccination, we did identify a code that was not uploaded into Cozeva, and all those claims were taken into consideration for 2017. They will show up on your payment report in terms of your that HTML report that you get to show that the gaps in care, and many of them, as you'll see, the numbers, the numerator numbers, will be updated. So we want to let you folks know that there was identification that one of the CB2, especially the flu vax, wasn't captured, and you'll be seeing a change in your numerator for that vaccination.
Right, but just keep in mind, we realize the flu season runs, it crosses over the end of the year from, say, September of last year to the beginning of this year. So if your patient got their flu shot last year, it counts for last year. For you to get numerator credit for a patient for this year, they would need to get a flu shot sometime this year, whether that's during the beginning of the year or the beginning of the next flu season. Otherwise, you will see a gap in care for that patient for the flu vaccine.
So the next question is, can the monthly attribution files be put on HHIN? And we can make the recommendation. Certainly that's something that we could try to have put on. Right now they're not, but we can make that recommendation. The next question is, so for our submission May 1st, and the answer is yes, we're going to wait for May 1st to put in information. And the other question is entering data into Cozeva for now. The answer is yes, you can enter information into Cozeva for supplemental data. However, we want to try to minimize as much supplemental data for now, and if it's on your claim, just wait for the claim to process for now. Otherwise, it'll be a lot of data to move over into Choreo, and it will just further delay the process of Choreo getting the information we need to make sure that you get the numerator credit. The next question is about the shared care real age assessment, and that is actually being captured outside of Cozeva for now. That information, as patients are being signed, we get a feed from shared care, and they give us the information whether that the assessment was taken, and then we input the information into potentially into Choreo later, but that for right now is put outside. So the next question is, can we find out the progress or updates on Choreo interfacing with any EHR EMRs?
So for the EHR integration, the integration process has been completed with Elation, and the providers that are on Elation should have already received consent forms for integrating their data with Choreo. We are also in the process of integration with both Queens and HPH Epic as well as eClinicalWorks. We just sent out a consent form for eClinicalWorks, and our team is working on updating that form and getting it out to the providers, and that will also go out shortly for both of the Epics. Beyond those three, the top 10 EHR platforms are targeted to be integrated by the end of this year, and we'll have more specific information directly to the providers on those various systems as we start integrating with the different systems.
We understand that some of you may have questions that may be specific to your office practice, and we will be following up with your engagement leads or your people that are on island to follow up with you with regard to your specific questions. If there are any other questions, please feel free to put them in now. Otherwise, we will go ahead and end the webinar for now, and we look forward to seeing you after the Choreo launch.
So I just wanted to remind you, you were sent an evaluation form with your slide deck. If you could please take a moment to complete your evaluation form and either fax or email that back to us, we would greatly appreciate it. And thank you so much for taking time out of your day to spend some time with us to talk about payment transformation and Choreo. And we hope to see you soon at our next webinar. Have a great day.